pleasure to welcome my friend and mentor, Bill Fearon, to Cardiology Grand Rounds at UCLA today. As way of background, Bill's journey started as an English major and a middle infielder on the baseball team at Dartmouth. And then after receiving his MD at Columbia, he ventured west, happy wife, happy life, and did his cardiology or his internal medicine and cardiology training at Stanford, joined the faculty afterwards and hasn't left since. Today, Bill is a professor of medicine and director of interventional cardiology at Stanford, also now the chief of the cardiology section at the Palliative VA. He is, as most of you know, a world-renowned authority on coronary physiology. His pioneering work on FFR and the FAME family of trials has led to the global adoption of FFR across the world to help guide revascularization strategies in the cath lab. He also derived and validated the Index of Microcirculatory Resistance, or IMR, which is now the gold standard physiologic index to assess coronary microvascular function, which is, an emerging etiology in our patients. Bill has amassed over 275 publications and has had near continuous NIH funding, but I think more importantly than those metrics, he really pays it forward, as evidenced by the multiple teaching and mentoring awards he's received. And most impressively to me is his uncanny ability to balance his clinical research and administrative responsibilities with the normal work-life balance, something all of his mentees, I think, try to emulate. So today, Bill is going to be speaking to us about FAME3, the latest trial to enter the foray of PCI versus CABG in multivessel disease. Bill, thanks again for joining us today. Really looking forward to your talk.
Well, thank you, Rishi. It's really an honor and a pleasure to be here speaking. I just wish we could be in person, but hopefully that'll happen soon. Can you see my slides okay?
Yes.
Great. Okay, great. These are my disclosures. I receive research funding from Abbott, Boston Scientific, and Medtronic, as well as the NIH, and have consulting relationships with CathWorks, HeartFlow, and Siemens. What I'd like to do in the next maybe 30 to 40 minutes is review historical data comparing PCI with coronary artery bypass grafting, or CABG, for multivessel coronary disease. Talk about what has changed since those historical studies, and namely development of current generation drug-eluting stents and coronary physiology to guide PCI, and then spend some time talking about our most recent efforts with the FAME3 trial. I thought I would start with a case presentation. This is a 53-year-old man with hypertension, dyslipidemia, and tobacco use who was admitted with chest pain. He was working as a radio frequency technician when he developed left-sided chest pain while walking down the hallway that he described as burning that lasted about 5 minutes and resolved with rest. However, he and his co-workers were concerned enough that EMS was called and he was brought to the emergency department. His exam was notable for him being hypertensive. Otherwise, he had a pretty normal cardiovascular exam. His initial labs showed a very slightly elevated troponin and hemoglobin A1C that was 5.9%. His lipid panel showed an LDL that was 142. His initial ECG is shown here, and you see that he has a sinus rhythm and perhaps a little bit of ST depression in the lateral leads, some J-point elevation in lead 3, and poor R-wave progression. So he was admitted, and the first question was whether he should undergo further medical therapy and non-invasive imaging, or should he move directly to invasive coronary angiography. And I would just highlight the recent coronary revascularization guidelines demonstrating a 1A recommendation for patients with non-ST elevation ACS who are at elevated risk of recurrent ischemic events being appropriate candidates for revascularization, that an invasive strategy with the intent to proceed with revascularization is indicated to reduce events. I would give a shout out to my colleague at Stanford, David Marin, and his colleagues who did the ischemia trial that has changed our paradigm in stable patients, where they found that an invasive strategy was really no better than a conservative strategy in patients, again, with stable coronary disease. and that we can start with medical management. But this patient, the feeling was a non-ST elevation ACS. And so following the guidelines, he was brought to the cath lab. And you see his left coronary here, the LAD, and he has a fairly high-grade proximal LAD lesion. The areocaudal view showing his circumflex system. And he has two lesions, one sort of proximal lesion, and then one more in his obtuse marginal branch. And then finally, his right coronary artery, which is a tortuous vessel with multiple areas of sort of questionable significance in the mid area, in the mid part of the right, and then the PDA looking a little bit more significant. So now we have a patient with multivessel disease in the setting of an acute coronary syndrome. Revascularization is indicated. So should this patient undergo PCI or CABG? And I'd like to talk about some of the historical data. This is a study that my colleague Mark Latke performed a meta-analysis for more than 10 years ago of 10 randomized trials at that time, over 7,000 patients, where they didn't find any real difference in death or MI during a longer-term follow-up between PCI and CABG. However, when they looked at subgroups, there clearly was an interaction with diabetes, where diabetic patients seem to do better with CABG compared to PCI. Now, these studies are likely, selected patients and performed at specific centers, and it's always good to look at registry data or more real-world data. And we have this study from about 10 years ago of almost 200,000 Medicare patients who were treated either with PCI or CABG. This again was not randomized, but the investigators did propensity matching and showed that there seemed to be a survival benefit with CABG, although small, compared to PCI in this very large study. Now, both this registry and that earlier meta-analysis included mostly bare metal stent studies and not too many patients with drug-eluting stents. And the first large trial to test first generation or the Taxus drug-eluting stent was the Syntax trial, 1,800 patients with three vessel disease or left main disease. About 30% were diabetic. They did do a pretty aggressive stenting strategy, 4.6 stents per patient, an average of 86 millimeters, and a third of patients had more than 100 millimeters of stent placed. And I think many of you are familiar with these results. At 1 year, CABG outperformed PCI with respect to death, MI, stroke, or repeat revascularization. This was mostly driven by lower rates of repeat revascularization. The investigators have now followed the patients out to 5 years, and there was a trend towards lower mortality with CABG at 5 years. There was definitely a significant difference in MI rates with CABG being lower, and a trend toward higher rates of stroke with CABG during longer-term follow-up. And so not surprisingly, when you factor in repeat revascularization at 5 years, the overall MACE rates were significantly lower with CABG compared with PCI. One of the important sort of outputs from the Syntax trial was the Syntax score. This is an angiography-derived scoring system for the complexity of the coronary disease. And as you can see, factors in all these different characteristics of the anatomy and helps to predict the outcomes after PCI or CABG. And when this was applied in the Syntax trial, you see that patients with less complex disease, the lowest tertile, a score of less than 22, had fairly similar outcomes between PCI and CABG at 1 year. And as you get into the intermediate and the higher tertile groups, there is a clear benefit to CABG over PCI. So what have we learned from these historical data? Well, patients with more complex disease and diabetics fare better with bypass. And this is when compared again to angiography-guided PCI and with first-generation drug-eluting stents. How do we explain this? Well, the classic explanation is that when we stent, we fix just the culprit lesion, but we don't address any other potential vulnerable plaques in the rest of the vessel. Whereas when we bypass, we bypass 2/3 of the vessel. So not only the culprit, but also potential vulnerable plaques, which would result in lower rates of MI, certainly during follow-up. But what has changed since these historical data were published? Well, the stent technology has evolved. We now have second and third generation drug-eluting stents, and coronary physiology, and in particular fractional flow reserve guided PCI, has been shown to improve outcomes compared with traditional angiography guided PCI, which was used in these earlier studies. So first, with respect to stent evolution, the first generation drug-eluting stents, which were the Cipher and Taxus stents, these eluted sirolimus and paclitaxel. These had thicker struts. They were made of stainless steel, a thicker polymer coating, and the polymer was durable and inflammatory, which played a role in the very late stent thrombosis seen with those stents. Current generation drug-eluting stents, for example, like the Xience or Resolute or Synergy stents that you may be familiar with, elute everolimus or zodorolimus. And because they're cobalt or platinum chromium, they are able to maintain their radial strength, but have thinner struts, and also have a thinner polymer coating, which is more biocompatible. And so this, as I'll show you, has led to lower rates of complications after these stents. One of the major studies was the SPIRIT trial, which looked at the everolimus second generation drug-eluting stent compared to the paclitaxel first generation drug-eluting stent. And you see that there's lower rates of MI out to 3-year follow-up in this randomized trial. And this was explained by lower rates of both early, late, and very late stent thrombosis, as well as lower rates of restenosis with the newer stent. And this translated to a mortality benefit when followed out to 3 years with the everolimus eluting stent compared to the paclitaxel eluting stent. So clearly some hard endpoints that are changed with these newer stents. What else has changed? Well, as I mentioned, fractional flow reserve is now used more routinely, or coronary physiology, I should say. And just to remind those who may not be in the cath lab or familiar with it, it involves placing a pressure wire where we can measure the distal pressure with the pressure wire, and we compare that to the proximal pressure in the coronary artery measured with our guiding catheter. And we generally do it when we're measuring FFR during hyperemia or maximal flow down the vessel, simulating stress or exercise. And so we give adenosine, like shown in this tracing down here, where the purple tracing is the mean and phasic distal pressure, and the red tracing is the proximal. And you see that at peak flow, the gradient or the ratio is 60/100, or the FFR is 0.60, meaning that 60% of the blood that should be getting to that part of the heart is actually getting there. And we've learned that anything below 0.80 is generally considered significant and correlates with ischemia and adverse outcome. Whereas if the value is above 0.80, medical therapy does just as well, if not better, than stenting in those patients. So the first study that really validated fractional flow reserve was the FAME-1 study. And this was a study of just over 1,000 patients with multivessel disease which was felt eligible for PCI. And these patients were then randomized to either the standard of care at that time, which is angiography guided PCI, where you basically stent whatever you think is significant based on the angiogram and any non-invasive data you have, or to FFR guided, where FFR was first measured, and only if the lesion was significant, less than 0.80, did you stent it. And these are the 1-year major adverse cardiac event rates, and they were significantly lower with the FFR guided patients. And this was due to a relative risk reduction that was similar for each component of the endpoint. And you see that death in MI alone was also significantly reduced with the FFR guided strategy. And one of the themes that emerged from the FAME trial was this difference between anatomic and functional coronary disease. When you look at the patients who had angiographic three-vessel disease, after FFR was measured, it turned out that the majority of these actually only had one or two vessel functionally significant disease based on FFR. And the reason that's relevant is because we can then derive what we call a functional syntax score. And Chang-Wook Nam, who was one of our research fellows at the time, did this sub-study from FAME where he took all of the FFR guided patients and calculated the syntax score first based on the traditional technique and without FFR, and then calculated the functional syntax score where you apply FFR, and if the lesion and vessel is not significant based on FFR, then you subtract it out from the syntax score. And as you can imagine, this reclassifies, in this case, a third of the cases from a higher risk to a lower risk score. And the reason that's relevant is because it turns out that the functional syntax score was a better discriminator for the risk of death or MI after PCI compared with the classic syntax score. And there was a shift in patients so that the highest risk group became a much lower percentage of patients and the lowest risk group much higher. And so one could imagine that by applying this strategy, one could better differentiate which patients might benefit from CABG, this high risk group, compared to those that could be more effectively or at least as effectively treated with PCI. Now, you may wonder, well, what about those deferred lesions? There were about 500 lesions in FAME1 that were angiographically significant. The operator had planned on stenting, but then when FFR was measured, they were not, and they were deferred. And one way of looking at that is by calculating the residual syntax score. This is after PCI, looking at whatever lesions are remaining and calculating a syntax score based on them. And as you can imagine, if you have a high residual syntax score, you would expect a higher event rate during follow-up. And that's what in studies looking at angiography-guided PCI have shown. But Yuhei Kobayashi, one of our research fellows at the time, did this study from the FAME trial and found that the residual syntax score was not at all predictive. So meaning that after FFR guided PCI, the degree of residual disease does not predict events when it's not functionally significant, i.e. not causing ischemia. So meaning that you can safely defer these lesions and the patients will have a reasonable outcome. One of the criticisms from FAME1 was that there was no medical therapy arm. And people said, well, if medical therapy had been applied, patients probably would have done just as well, if not better. And so that was the impetus for the FAME2 trial. This was a study looking at just stable patients with single or multivessel disease. And the key difference between FAME2 and, say, COURAGE, and actually ischemia to a degree, was that FFR was measured first in all target lesions. And the reason this is important is because it turned out about a quarter of lesions that the operator felt were significant and required stenting were not significant. And so these patients went into a registry because we know medical therapy does just as well, if not better, in those patients. And so in this way, the study included an enriched population of only those patients with truly ischemic lesions. And then those patients were randomized in a one-to-one fashion to medical therapy alone or to PCI plus medical therapy. And the primary endpoint was death, MI, or urgent revascularization at 2 years. And what was found was that the red line are the patients who had functionally significant disease but were treated medically. The green line are the patients that had non-significant disease and were treated medically. And the blue line are patients who were identical to the red line, but randomized to PCI. And you see that once they had PCI and their ischemia was relieved, they had similar outcomes to the registry group. Now, one of the criticisms of this study was that most of this was driven by urgent revascularization. And this wasn't a sham-controlled study. Technically, the patients weren't blinded, nor were the following physicians, although one can argue that whether or not they really knew the FFR results. And one argument to show that there was no evidence of bias is this sub-study looking at all of the medically treated patients in FAME2 and looking at their adverse event rate based on their FFR. And you see that there's a clear relationship. The lower the FFR, the higher the adverse event rate, suggesting a real biologic correlation, and that this wasn't driven by bias or patients knowing that they had lesions that were left untreated. If that was the case, you'd expect more of a dichotomous thing. Either, they had an abnormal FFR, they had an event, or they didn't. And so I think this really argues that the urgent revascularizations weren't just due to patients knowing that they had lesions left behind. Another argument that there wasn't bias was that when you look at 5-year follow-up from FAME2, the hard endpoint of spontaneous MI was lower in patients who received PCI compared to patients who had significant lesions that were treated with medical therapy alone. And this mirrors what was shown in the ischemia trial, where spontaneous MI was also found to be lower with revascularization during follow-up. Now, again, those studies, FAME 1 and 2, are randomized studies, select populations. So it's good to look at more real-world use. And this is an elegant study that Rushi Parikh published in JACC recently, looking at outcomes in almost 18,000 stable veterans who were broken down. They had intermediate coronary disease and stable coronary disease, and they were broken down by whether or not they had angiography-guided treatment or FFR-guided treatment. And what you see here is one of the main findings was that all-cause mortality, even after adjustment for differences in site and procedural characteristics, as well as baseline characteristics, was significantly lower in the patients who had FFR-guided treatment. He also showed that the rate of FFR is increasing, particularly in patients undergoing PCI, from around 40% up to about 75% most recently. So what we've learned thus far is that FFR identifies lesions which are not hemodynamically significant and will respond well to medical therapy alone. This avoids the acute and long-term risk of unnecessary PCI. On the other hand, FFR also identifies lesions which are hemodynamically significant, where the benefit of PCI outweighs its risks. So with that background, the objective or primary hypothesis for the FAME3 trial was that to demonstrate that FFR-guided PCI with a second-generation drug-eluting stent is non-inferior to CABG in patients with multivessel coronary disease. This study was funded by research grants from Medtronic and Abbott, but Stanford was the sponsor of the study. We had an independent clinical events committee, as well as data safety monitoring board, who helped to coordinate the study as shown here. This, again, was investigator-initiated, multicenter randomized controlled trial, including all comers with 3-vessel disease not involving the left main. The heart team at each site had to agree that PCI and CABG were feasible. And the study included 48 centers in Europe, North America, Australia, and Asia. And patients were randomized in a 1-to-1 fashion to either FFR-guided PCI, where lesions with low FFR were stented and those with high FFR were managed medically, or to bypass therapy. And the primary endpoint was the 1-year all-cause death, MI, stroke, or repeat revascularization. The non-inferiority margin was set at a hazard ratio of 1.65. So looking at baseline characteristics, the average age of patients was around 65. This included mostly white men who had typical risk factors. About a third were diabetic, about 40% presented with ACS, and about 15% had had a prior PCI. Procedural characteristics demonstrated that the time to procedure, the procedure duration, and the length of hospital stay were all lower with PCI compared with CABG, not surprisingly. The number of lesions identified was similar, just over 4. About 20% of patients had one chronic total occlusion, and about 2/3 had bifurcation lesions. And the syntax score, the mean was 26, and you see the breakdown here. Most fell into the low and intermediate category, although about 20% were in the high syntax score. Now, as far as the primary endpoint, again, it was death, MI, stroke, or repeat revascularization at 1 year. And that occurred in 10.6% of the PCI patients and 6.9% of patients randomized to CABG. The hazard ratio was 1.5, with the upper bound of the 95% confidence interval being 2.2, which was above our non-inferiority margin of 1.65. So PCI did not meet the criterion set for non-inferiority, and the p-value was 0.35. When we look at the individual components of the primary endpoint, there were no significant differences in death, MI, stroke, or repeat revascularization. And death, MI, and stroke, although numerically higher with PCI, also wasn't significantly different. When we look at some safety endpoints, severe bleeding, acute kidney injury, and significant arrhythmia all occurred less frequently in the PCI group. Fortunately, definite stent thrombosis and symptomatic graft occlusion were infrequent in both groups. Rehospitalization within 30 days was also significantly less frequent in patients undergoing PCI. On subgroup analysis, there were some interesting findings. There were some trends towards differences based on age and sex, with young men doing best with bypass. But the most remarkable finding was with the syntax score, where the least complex patients seemed to do more favorably with PCI, and the more complex did more favorably with bypass. So if you look at the low syntax score, you see that numerically the PCI arm actually had better outcomes compared to CABG. But then when we go to the intermediate and the higher risk syntax score, you see the opposite, where CABG does better than PCI. It's important, I think, to compare FAME3 to the historical control, so to speak, the syntax trial. When you look at baseline characteristics, it turns out that a fairly similar population was enrolled with similar characteristics, similar number of diabetics, similar syntax score and ACS presentation, and similar number of lesions identified. But interestingly, in FAME3, both groups, the PCI and the bypass arm, outperformed, at least numerically, the CABG arm in the syntax trial. And so I think this is good news for our patients in that things have really improved. And when we designed the study, we designed it with an endpoint like was seen in the syntax CABG group. And we would have probably met that non-inferiority margin if bypass had performed that way. But you see, bypass did unexpectedly well in FAME3. Another thing to look at whenever evaluating a study is not getting too much into the weeds, but the definitions of the endpoints. And one thing that has been controversial is how procedural MI is defined after bypass and after PCI. And in FAME3, we used the same definition. We thought this was important so that the clinical events committee could adjudicate events in a blinded fashion. And I don't really think there should be a different definition for procedural MI between these two procedures anyway. The definition, you had to have an elevated troponin and at least one of the following, either new Q waves or demonstrated graft or native artery occlusion or imaging evidence of new loss of viable myocardium. So fairly strict criteria, and that's why the procedural MI rate was pretty low in FAME3 and similar between the two groups. Now, there's another definition for procedural MI from the Society of Cardiac Angiography and Interventions, which has been shown to be prognostically relevant. And it has two components. One is just a biomarker-only component where you just have to have either CKMB or troponin elevation to classify as an MI, or an elevation of biomarker that's not quite as high and new Q waves. And it's interesting when you look at FAME3, if you apply this SCAI definition, first of all, the rates are much higher than the FAME3 definition. And by the way, the FAME3 was it was almost identical to the universal, third and fourth universal definition of MI for the CABG group. But the other thing that's interesting is that the PCI arm had about a 4% lower rate of procedural MI. And so it just shows how if you choose different endpoints, this could have totally changed the interpretation of the study compared to this endpoint for procedural MI. So getting back to the case that I presented in the beginning, this patient with 3-vessel disease, he actually presented 3 years ago and was enrolled in the FAME3 trial at Stanford. And so we began by measuring FFR of his LAD and found that it was quite abnormal. And so he underwent he was randomized, by the way, to FFR guided PCI after meeting with the heart team and being consented and everything. So he's brought back to the cath lab, had FFR measured and had PCI of the LAD. His circumflex also was highly significant, both lesions. And so he had PCI of both of those lesions as well. Interestingly, that right coronary disease was not functionally significant. And we see this particularly with the right coronary and with the circumflex, that there's this angiographic functional mismatch where often the disease looks severe, but because those vessels don't supply as much myocardium, functionally they're not significant. So that was managed medically. And he actually returned to my clinic about a few months ago in November. He's had no intervening cardiac events. He continues to feel well and is able to walk about 3 miles without symptoms. He's currently on dual antiplatelet therapy, a high-dose statin, ACE inhibitor, and beta blocker. His blood pressure is better controlled, maybe although not ideal, and his LDL is now 57. So he had a very good outcome and probably or would have fallen into that lower syntax score group, I think. So in conclusion, in patients with 3-vessel coronary disease, FFR-guided PCI with a current generation drug-eluting stent did not meet the criterion set for non-inferiority in comparison with CABG in terms of death, MI, stroke, or repeat revascularization at 1 year. The 1-year rate of death, MI, or stroke was not significantly different between the two groups. In FAME3, MACE rates for both the PCI and the CABG arm were lower than the CABG arm in the syntax trial. FFR-guided PCI with current generation DES performed favorably in comparison with bypass in 3-vessel disease patients with less complex disease, according to the syntax score. However, in patients with more complex disease, CABG remains the treatment of choice. So what's next? Well, I think quality of life analyses are clearly important in this subset of patients. Many patients will sacrifice a higher rate of an endpoint like repeat revascularization if they're going to feel better. And we're looking forward to presenting these data actually at the ACC as one of the late-breaking trials. So we'll have those data to come soon. Identifying subgroups who benefit most from bypass and those in whom PCI is a reasonable option, I think is also important. And we'll be doing some sub-studies looking at the syntax score, functional syntax score, completeness of revascularization. And I think that data will be very informative. And of course, long-term follow-up is critical. One would expect that the benefit of CABG may further accrue with longer-term follow-up. And so these patients are being followed out to 3 and 5 years, and we look forward to those data again as well. So thank you for your attention. And again, thanks for the opportunity to present at Grand Rounds.
Thanks, Bill. That was a phenomenal talk. I think we have some time for a Q&A. I guess I wanted to start off with one question that you kind of got to at the end, which is, purists will look at the FAME3 trial and say the primary endpoint is negative. And so, the secondary endpoint, such as looking at the low syntax scores, hypothesis generating or, violates proportions and so forth. So I guess how do you respond to that, and how has this changed your practice when you meet with patients with multivessel disease and low syntax scores now?
Yes, a great question, Rishi, and I agree. Our statisticians agree with me, as well as did the New England Journal of Medicine when we tried to highlight that finding more. They wouldn't allow us to do that, and that's understandable. I would push back a little bit in that there is, precedent, other data like in the syntax trial supporting this finding. So it's not just a, incidental finding. Also, there's sort of biologic plausibility as to why this would be the case. And it was a pre-specified secondary endpoint and analysis. Now, we didn't power for it. So from a statistical standpoint, I agree it's only hypothesis generating, but I do think it's a real finding and that it makes sense. And I would say also that this issue may have skewed the study in a way, because I think a lot of the sites who were participating in FAME3 were already active coronary physiology users. And so a lot of them, I think, when they were faced with a 3-vessel disease patient, despite our sort of recommendation that investigators do what's done most commonly in the community, where people are referred for bypass based on the angiogram alone, many sites measured FFR first. And, patients who had angiographic 3-vessel disease, a number of them probably only had 1 or 2 vessel disease and just went straight to PCI and were never included in FAME3. And I think that could have skewed the population to a little bit more of a complex group, as was reflected by the syntax score. We had been hoping to have a lower syntax score because, the syntax trial had showed that in the really high complex patients, CABG has clearly been, wins. And so I do think that may play a role. And that is how, in my practice, I'm treating these patients. I'll measure FFR first. And if it turns out that they only have 1 or 2 vessel disease, then I would opt for PCI. Whereas if they, especially if they have CTOs and, bifurcation lesions, then clearly I think bypass is the winner, at least currently.
Hi, Bill. This is Ravi Dave. I have a quick question for you. So the one thing that we are finding, even with our surgeons who are, very good at performing surgery, have great outcomes, is that patients with high syntax scores who have perhaps not enough targets for grafts, and I know they don't particularly fit the inclusion criteria that you used in the FAME trials, but very often we get these really sick patients back to us to be treated percutaneously. And it always almost becomes a head scratcher, because here we are kind of using their trial information and getting clearance on the low syntax score patients. But in real life, we are treating patients with very high syntax scores, which the surgeons are, because they want better outcomes for the registry or whatever the reason may be, we get those back. So so that's a challenge that we are facing. I don't know if you're seeing that at Stanford as well.
Yeah, hi, Robbie. Yeah, thanks for that question. Yeah, that I think that's an issue everywhere. And I think it raises an interesting point in that I think one way of redesigning the study, or the next study that would be really interesting to look at, would be looking at 3-vessel typical bypass surgery to a hybrid bypass, where maybe an off-pump Lima to LAD and then PCI to the other lesions, and seeing how that performs. Because I think of course, there's some cases where the LAD is not a good target, but a lot of times it's the other vessels that aren't great targets. But I think if you could get at least, I think the biggest bang for the buck with bypass is the Lima to LAD. And if you can get that down and then do PCI of the other lesions, that's oftentimes a nice strategy. But, of course, there's some cases where, the surgeons just don't feel anything is feasible. And then we do the same thing and just try to do the best we can with PCI, knowing that, the outcomes aren't going to be as good as if they had less complex disease.
I had one other question, which is related to the topic, and that's with the REVAS guidelines that were published in December, January. And my disappointment is that when it comes to evaluating the severity of lesions, there's always something in the guidelines that leaves a little question. For example, the guidelines clearly state that for left main stenosis, you can use intravascular ultrasound criteria. But when it comes to non-left main lesions, all of us that believe in physiology only use physiology as the gold standard. But if you look at the guidelines, they kind of throw in this vague sentence that, well, intravascular ultrasound can be considered, and then the references that they quote in these REVAS guidelines really are outdated references, and definitely don't give you any exact numbers that you can go by. So that ends up creating a problem, because that sort of leaves a door open for people to start using ultrasound to evaluate stenosis, which by FFR or IFR would be negative, and then inappropriate lesions start getting treated.
Yeah, I think you're getting at a great point here. Just the lack of good data that we have for evaluating left main lesions, and it's definitely an area of need. I think in my practice for left main, I will generally start with physiology and measure FFR, and ideally do it in the LAD and circumflex. It can be sometimes confounded by downstream disease, but we try to do our best. And if one vessel is not involved, does not have downstream disease, I think you can rely on that in most cases. And then if we have a question, if it's not clear what's going on, I'll do imaging as well and do IVUS, and then obviously taking into account the clinical characteristics. But I think you're right. It's unfortunately just a carryover from historical, biases that to use IVUS and left main, there's a no clear cutoff point. And I mean, fortunately, it does correlate pretty well with physiology, just because the amount of myocardium supplied by the left main in most people is pretty similar, and the size is pretty similar. But of course, you see data from Asia where there's smaller patients and they have a smaller cut point compared to the United States and Europe. And so it definitely is an area where we need some more good data.
Can I ask a question, Rishi? This is Jesse Courier. I was disappointed in the FAME3 trial in that only about, I think, 10% of the surgical patients had FFR-guided selection of grafts. I don't know if I came in a little bit late because I was cathing. But I was wondering what you thought about FFR guidance for grafting, especially for arterial conduits, because I've seen probably 10 or 15 cases in the last couple of years of patients who get a lima for an FFR borderline lesion, often in the gray zone, and they're atretic. And so I don't think that the same thresholds necessary that we use for PCI actually pertain to bypass. Can you comment on that?
Yeah, it's a great question. I think I'll take it in parts. Maybe the first part is, why didn't we mandate FFR guided CABG? And there were a few reasons. One was logistical. And so, a lot of centers participating would have patients referred who had had an outside angiogram that showed 3-vessel disease. And if they were to undergo FFR first, they'd be brought to the cath lab, have FFR measured. And then if they randomized to CABG, they would then go to CABG. They would end up getting basically an extra angiogram. And that was logistically challenging to deal with. because you'd have to find a way to pay for it. And also it would mean doing 2 procedures in a patient. So that was one reason. The other reason was, to be honest, many centers still don't do FFR before they send patients to bypass. They just base it on the angiogram. And we wanted to kind of mimic current practice. And also, if we had done FFR, again, a lot of the patients would have had only 1 or 2 vessel disease, and they wouldn't then have become part of the study. And so it would have kind of been like shooting ourselves in the foot. So, all you'd have is FFR positive lesions. So those were the reasons why it wasn't done. Now, from a scientific standpoint, that's a great question. Would that have changed the outcome, or were we biasing against bypass? And I think the studies have shown, like you mentioned, that FFR does predict graft patency. And so if you have a borderline FFR, or certainly if you have a negative FFR, there's a much higher chance that the graft will be occluded at 6-month follow-up compared to if you have a low FFR. That was done in a very nice study from the Netherlands, where they measured FFR and didn't tell the surgeons, and then sent the patient to surgery. And then they brought the patient back and cathed them again 6 months later to see what was open and what wasn't. And they found that, a lot of the FFR negative lesions that were bypassed had occluded grafts. Interestingly, though, that study and others too haven't really shown much clinical difference in outcome. There have been a couple randomized studies looking at FFR guided versus angio guided CABG, and they showed things like, fewer grafts needing to be done. Maybe the operative time is a little bit shorter, but when you look at clinical endpoints, there aren't really substantial differences. So I don't believe that we really bias things. I mean, the CABG arm did great in FAME3. It's hard to argue with that event rate. So, I think, in our daily practice, yes, we will measure FFR. And I would say one caveat to that, and this was how I enrolled patients in FAME3, and I think a lot of other sites did this. If the LAD was borderline, I always measured FFR first before sending them to CABG, just because I think, the downside of having them undergo a lima when they don't have a significant LAD is too high and didn't really feel ethical to me. So I do, and we saw that when you look at LAD lesions in FAME3, like the vast majority of them, of those patients who were randomized to FFR guided PCI, had significant LADs. I think because of that reason.
This is Dan Silverman. So it's common, of course, to have as a composite outcome include repeat revascularization, but it seems to me that when the trial is specifically comparing 2 different kinds of revascularization, that may not be as fair or as relevant, because there probably are a lot of people who would rather have 2 PCIs than 1 CABG. And so I guess there's 2 questions. One specific, probably the answer is that it wouldn't in your particular trial have changed the outcome if you had left that out. But the more general question is, what do you think in future trials to not include that as part of the primary outcome measure in the composite score?
Yeah, excellent point, and well taken. I think it is one of the criticisms of FAME3 for sure. The rationale behind it was that we really wanted, in a sense, to try to replicate syntax with the same follow-up and the same endpoints, but the only difference being using current generation DES and using FFR guidance. And then so that we could really eliminate other variables and see exactly how that impacted things. We do have a pre-specified key secondary endpoint of death, MI, and stroke at 3 years that I think will clearly be relevant and help guide decision making. I think you could also argue that you should include quality of life outcomes. People, like I said, care more about that, and maybe you should have a composite that includes quality of life and gets rid of repeat revascularization. So that was the reasoning behind it for the decision. But I think you're right, and I agree completely that a lot of patients would gladly undergo 2 PCI to avoid a sternotomy.
Thanks.
So there's a couple questions in the chat. I don't know if you can see those or if you want me to read those out loud.
Yeah. So that's a great question by Dr. Patel about, we still in FAME3 had, like I mentioned, a largely white male population. So I think it's an important point and definitely an area that we need to improve on. I would say there is a study being designed that's only going to enroll women and underrepresented patients in clinical trials. And it's an NIH, well, it's going to be proposed to the NIH. We'll see if it gets funding, but I think that will really be important because, yeah, you can't, I don't think, apply these data to patients who weren't enrolled in the studies. And so, it's a definite limitation of the FAME3 trial. The other question about FFR during ACS is a great question. And I would say in STEMI patients, we do not measure FFR in the culprit vessel because of the transient microvascular dysfunction that can occur. The issue there is that when you give adenosine, you may not get maximal hyperemia, and so you may overestimate the FFR. Whereas if you were bringing the patient back a few weeks or months later, once that stunned portion of the myocardium has recovered, you may get a lower FFR across, say, if there's a residual stenosis after you treated the culprit. And so we do not recommend it in the culprit lesion. In non-culprits, there are a number of studies, and many of you are probably familiar with the FFR MI, which just came out, showing that it is reasonable in STEMI, although there is still some question raised by that study about whether you're missing some, vulnerable plaques that are not functionally significant. And I think that's an area needed a further investigation. In the non-STEMI population, at least in my practice, if you have a clearly like a subtotally occluded or thrombotic vessel, and this was the case in FAME3, FFR was not mandated in that. You would just go ahead and treat that. But for non-culprits, I think it's very reasonable. And I do think the data for supporting physiology in the non-culprits and non-ST elevation ACS is valid. So I will use it in that setting.
So I had one more question, kind of piggybacking off some of the comments that Ravi and Jesse made. Some of the criticism of FAME3 was also regarding the low use of image-guided PCI to optimize the stent. And of course, I think the low rates sadly mimic the, that is real world. Unfortunately, that only about 10% of people are doing image-guided PCI. Question is, could you envision, it probably wouldn't get funded, but a repeat of this trial where image-guided PCI was mandated in addition to, FFR-guided PCI, and do you think that would have substantially changed the outcomes based on some of the imaging-guided data that we have now?
Yeah, it's a good point. And when we designed the study in 2013, 2012, a lot of the data that have now become available really supporting intravascular imaging to guide PCI weren't available at that time. And so if we were to do it over again, we would certainly pay closer attention to that. I would say it's interesting that there was a study called Syntax 2, which was basically a registry study where the Syntax investigators just did PCI in about 500 patients using intravascular imaging in about 85% and also physiology to guide it. And then they compared outcomes to the historic control surgical arm from Syntax 1. And they found that it compared very favorably. When you look at the population they enrolled, they were similar to what was in FAME3. In fact, maybe even a little less complex. The Syntax score was only 20 in Syntax 2. But interestingly, the MACE rate was 10.6%, actually the same as the PCI arm in FAME3. And the repeat revasc was the same too. And now I know this is sort of comparing apples to oranges, but it does raise a question was, did the imaging really help things and would have it changed FAME3. And FAME3, as you mentioned, only 12% of patients had intravascular imaging. So I do think, the data show that it improves outcomes. And so we would certainly in the more complex patients, the patients with longer lesions, the ACS patients. And so we would have done it more if we were to redesign the study now. But yeah, I'm not so sure it'll get done. Yeah.
I would say the problem, Rishi, is for FAME3 was not that there was bad outcomes in the PCI group. There was the surgical outcomes were so good. I mean, the PCI outcomes were very good, which is precisely why there's such a low uptake of imaging, because you do pretty well with doing minimal imaging, so it's hard to improve on those results, I think, in FAME3, because they were pretty darn good to start with only a 10% or 12% imaging rate.
That's a fair point. Any other questions? We're at the end of the hour, but again, Bill, thanks so much for presenting today. I think it was a great discussion, and I think everyone learned quite a bit.
Great. Thank you again, Rishi, and thanks everyone for joining.
Thank you.
All right. Thanks.
Great to
Yeah.
see you, Bill. Thank you so much.
Thanks, Carol. Take care.